Yes.
Great. So, a little bit of introduction. I won't spend time reading to you, but we brought this together. Dory and I got to do this before, so we did it with a bunch of trust officers and attorneys down in Florida. They seemed to like it, and we thought it would be good to bring to the Special Needs Alliance Conference, so thank you for having us. I've been working in mental health for quite some time, and I think that most people here know that mental health and the field of mental health, or at least navigating treatment, is pretty difficult. So it's a beast of its own. So by the end of this, what I want you to do is just going to want to have a conversation. I want to talk to you about what it is navigating mental health and solutions, give you a framework for navigating it to a certain extent for yourself, and where to find resources and where to kind of end the crisis cycle. And here in a minute, most people don't know what a therapeutic consultant is. I'm not sure I know, actually. All I know is that navigating mental health is complex. It takes a lot of work. What we do is we travel the country and we evaluate programs and we figure out where people need to go in order to stop this crisis cycle. So we want to talk about how all of that works, how we treat complexities, treatment capacity or treatment modalities, as well as levels of care. So there's a lot to this system before a person actually gets stable and gets to a place where they can find good care managers and land somewhere and not bug the heck out of their trust officer and asking for money constantly and those kinds of things. So, and then Dory and I are going to do a little bit of a case review and talk about some cases we've worked on together. So there we go. What is a therapeutic consultant? Again, I don't like reading to people, but most of the families that reach us, their family member is in crisis. They've gotten into the hospital, maybe they're in jail, they've gone off their medications, they've gone psychotic, they've gone missing, they've gotten into some kind of trouble and they don't know, the family doesn't know what to do with it, and even when they've got attorneys and trusts involved, they don't necessarily know what to do with it now either. They know what to do with most people are really good at long-term care, something that's stable going on, but when they get into crisis, where do we turn? What's the problem that we're facing? That's where a therapeutic consultant comes in. We help navigate that problem for people, figuring out not only what is the condition that we're dealing with, what is the appropriate kind of care, what is the appropriate level of care, how long should that last before they become stable enough to get back towards whatever level of independence they're prepared to be at. So this is just a sample of some of the diagnostic profiles in the DSM. Anybody familiar with the DSM, Diagnostic Statistical Manual of Mental Disorders? So you've probably seen some of these, or at least heard of them. Autism spectrum, borderline, bipolar, anxiety disorders, depression, mood disorders, schizophrenia, schizoaffective disorder, and that's just a grab sample of diagnostic profiles that are in the DSM. Anybody that's seen the DSM knows it's about this big. It's had about 10 edits, and it's a beast to get through. So you know that is barely scratching the surface. So how do you treat all those? So the first problem that you face is most people have been in and out of the hospital system. They've not really been diagnosed. Maybe they spent 2 days in the hospital, maybe they spent 5, heck, maybe they spent 2 weeks. I've seen people spend more, but largely it's a short-term stay. They get very little time with a psychiatrist who's spending 20 minutes giving them an evaluated profile. They're bipolar, let's give them Haldol, let's give them Thorazine, calm them down, send them out the door, down the street. Yay, problem solved. And not only do we have a very limited diagnostic profile on this person, we also have a very limited treatment profile. So medication management. So the next slide here is just a grab sample. This is 3 pages of different treatment modalities that you can use for treating various conditions. Medication management is the single most highly used treatment modality that we in the United States offer to people who suffer from severe and persistent mental illness, because we don't know where they're going. Are they going to get care afterwards? I don't know. Do they got any money? I don't even know if there's a residential program that'll take them. I don't know if they've got enough money or insurance to afford it or whatever, so I'm gonna dump them with a bunch of meds, I'm gonna hit them on the street and push them to basketball. Maybe they'll get with services that are local to your community, maybe they've got an IAC team, maybe they'll go to the IOP. None of which is really appropriate for care for a person who's just come out of the hospital for a psychiatric condition. So, no wonder they end up cycling through the revolving door all the time. So, medication-assisted treatment, depending on where you go, if a person's got substance use issues, you've got substance use treatment providers that don't believe in MAT, and you've got others that are strong components of it, and there's a narrow band down the middle, so you get a lot of disagreement in that field. Cognitive behavioral therapy, it's kind of the gold standard for treating people with trauma disorder. DBT, you probably heard of exposure therapy. Anybody know what exposure therapy is for? What's exposure therapy for?
PTSD.
PTSD, OCD.
Phobias?
I'm sorry?
Phobias?
Yes, absolutely. So, ECT, Nurse Ratched, right? They don't do it that way anymore, thank goodness, but that's the image we all get, right? Group therapy, family systems therapy, EMDR. Anybody done any EMDR? Yeah, so EMDR is pretty commonly used for a wide range of people, but it's really good for PTSD and trauma and that sort of thing. Art therapy, equine therapy. There's all kinds of modalities that are out there. So the trick is, and the problem that we end up having to solve, is matching the condition with the treatment. So that's problem one. First, we got to get the right diagnosis. What are we treating? Second, we figure out how we treat it. What's the right treatment modality we're going to use? Third, we got to pick the level of care. So there are levels of care, and each one of these levels of care have a different lengths of stay. And the lengths of stay are on a spectrum, right? So hospital is your highest level of care. They can lock you in. Down below that, you've got crisis centers, stabilization centers, and diagnostic centers, often kind of coupled. Diagnostic and stabilization. You'll see those, and they might be attached to a hospital, or they have a relationship with a hospital, so if a person gets acute enough, they can just send them over there, calm down for a minute, and come back and start figuring out what's going on. But even that, that kind of evaluative program is going to last at least 2 weeks, sometimes a month, sometimes 6, because especially for a person who suffers from thought disorder or schizophrenia, if you just had a psychotic episode and you start assessing the person immediately after the psychotic episode, what happens? The psychotic features scream so loud, you don't actually get anything about what's going on underneath. You don't understand whether it's trauma, is it a mood disorder, and if they go over the top of the mood disorder, they're having psychotic features, or they really just truly have psychosis and they need to be an honest antipsychotic all the time. Like, you don't know, because you're too busy hearing the loudness of the psychotic episode. So you gotta let them cool off a little bit before you start assessing. After these hospital/clinic kind of care, residential care. And most providers, even good programs, don't really know more than what's in their area. So they may, and if you don't live in an area like Kansas City, for example, there is not really, if you want high quality residential treatment in Kansas City, you're gonna have to drive to Ohio. So, now that doesn't mean you can't go to the hospital. You might find an IOP or an outpatient center or something like that, but if you've got a pretty severe and persistent condition that needs a lot of care and needs a lot of diagnostic work, it's not here. You're gonna have to go out of state. Most people don't know where those resources are. One of the things that we do as therapeutic consultants is we travel. Our team visited 250 programs across the nation last year. You've got to travel. You've got to go kick the tires and meet people and see programs and learn whether or not they can do what they say they're going to do. What is their cost profile? Is in any slide? Are they in network with insurance? There's all these questions we have, and we try to get those questions answered by visiting programs and developing relationships and saying, hey, what kind of person is the person that you serve? What kind of treatment do you provide? Residential treatment, length of stay, anybody know? What would you guess? Most people will think 30 days. I would say somebody with a severe and persistent mental health condition needs at least 60 to 90. So you look at a spectrum. 30 to 90 days worth of care. We say 30 days. Why do we say 30 days? Because that's what insurance will pay for. They put those what I would call false treatment periods into play back in the 90s when I started in the field. I've been in the field since 1994. In 1995, managed care came in and said, you know what, we're chopping these off and we're dictating treatment periods. 30 days was it. So, at any rate, you get residential treatment, 30 to 90 days, and then most people, one of the most vulnerable steps you'll ever take. So, anytime you're coming from a highly structured clinical environment, everybody's caring for you, they're talking to you, they're helping you calm down, they're helping you process your problems and everything else. Now you're going to step down, you're going to go home. And then there's no clinicians and there's no support and there's no anything else. It's probably one of the most vulnerable steps a person takes. If they don't do something to transition from a residential environment to a supported living environment of some kind that's capable of managing someone with mental health conditions and med management issues and all the other things that come along with that. They have anxiety, they don't sleep well at night, they need med adjustments, all those pieces. It's complicated stuff. You need people who know how to do it and then stay on top of it. Because when you don't stay on top of it, what happens? You go back to the hospital. So 30 to 90 days residential, step down care, you've got 2 levels of care that kind of follow from there, PHP and IOP. Do we know what those are? Partial hospitalization. Some come with residential placement, some are just standalone. They belong to a community. A lot of these folks that are coming from this kind of hospital experience, they need a supported living environment while they do PHP and IOP. If you're a person with a severe substance use issue, the chances are good this process looks like 2 years. And at the end of PHP and IOP, 6 to 9 months, we're just sober living. Standard, supported, sober living. You're going to meetings, you've got coaches, you've got people that are helping you manage that. What's the date on which most people who suffer from a substance use issue relapse more than any other?
Oh.
Their year anniversary.
Oh. Wow.
Next would be the day after they leave. And it depends on when, did they just leave 30 to 28 days worth of care? Yeah, that's probably true. But for people who have managed to be sober while they were in treatment and follow through the plan, their year of sobriety is one of the most flagrant relapse periods for most people with a substance use issue. So you got to get 13 months. 1 year gets you 2, 2 years gets you 5. That's what they say. That's the math. So, levels of care, lengths of stay, and if the people, especially the people that you folks are seeing that have these kinds of conditions, they don't play small. There's the worried well, right? And then you've got people who start to suffer from mental health conditions, maybe it's depression, maybe it's anxiety, it starts to pop over a line where it starts to interrupt their life. Having trouble showing up at work, having problems with relationships. That's when a mental health condition or a substance use condition starts to become what they call clinically significant, right? And you can start to have a diagnosis. So when you pop over that line, you go to the next line, you've been hospitalized, you've got a psychiatric event, you've had a suicidal ideation, you've gone to the hospital, you stayed at the psychiatric hospital for 2 weeks, you've crossed another line. And the chances that you can just ignore it and go back to life as it was, pretty slim. And you might need some level of all of this. There are some people that have, older, and they have families, and there's other kinds of things. Maybe they go home, but at home, we dial in a lot of support around them at home. So we make their PHP environment at home. They've got good support, they've got people to talk to, they've got a great therapist, they've got a good doc, etc. So, if you don't follow your plan, the chances of the cycle starting over, really high. This is about supported independent living. I probably don't have to talk too much about this. I'm not going to read that slide to you. Everybody knows this, but if you've got people who suffer from psychiatric issues or substance use issues, wherever they go for this, needs to be services that know how to do that. Because if they don't know how to do it, you get somebody who's bipolar with psychotic features, with substance use issues, and you send them to the standard sober living down the road, chances of them doing high quality bed management are slim, and that person's gonna go psychotic because they're gonna go off those meds. Happens all the time. It is the bane of my existence. So these are the gaps where they all kind of fall apart. Legal entanglements, repeated arrests, toxic family dynamics. You don't deal with any of that, do you? Insufficient level of care, length of stay, chronic relapse, isolation, poor and insufficient care, poor medication management, all these pieces. This is all the stuff that happens in these people's lives without support that cause them to cycle back through and create headaches for their care managers and create headaches for the trust managers, because when they go unstable or when they get back and they go on a bender, what do? They spend all their money. They call you up constantly, 3 o'clock in the morning. I've popped a tire, I need a new lawnmower, whatever it is. Like, you're seeing all these things because this person's now symptomatic. And we've got a case that we'll talk about where it really nails this home. So, at any rate, the role of the trust officer, role of care manager, I could put that slide in here too, I don't have to tell you what that is. Role of the therapeutic consultant is that we help families navigate all this and help that person get back into stability so that they can return to the care environment that is sufficient for the trust or the trust managers, and ideally, if they've had a care team that work, get them back to their care team so that they can pick up where they left off. You catch them early enough before it comes to a crisis, get a little stabilization period going on, they can return back to the environment and pick right back up their team. They got trusted relationships and therapeutic relationships that they trust in a community that they know, and you can avoid having them lose that entirely. That's the best scenario. A lot of times we get them and they've just gotten way too far. And sometimes we have to go out of state for care, and they may or may not return. But we do all kinds of things like write reports and take calls in the middle of the night. I have one of Dorian's who likes to text me at 9 or 10 o'clock at night. I just text him back because it's easier. It's not long, but my one-word text messages to his long diatribe. Yeah, that sounds hard. So, at any rate, so what we thought we'd do is Dorian and I would take a few minutes just to talk about some of these. And the one that I was referring to before, this 50-year-old male, this is my namesake. This is my separated at birth twin. We're about the same age and we have the same name. And so, I don't know, Dorian, do you want to?
Yeah, sure. So, backing up a little bit, I've been in my role for now 11 years, and so I've come to these conferences quite a bit, and it's always sort of a reoccurring theme, right? Of how do we deal with these beneficiaries or these clients who have severe and persistent mental illness and whose behaviors are creating obstacles for us in doing our jobs. How do we deal with that? For the longest time, we really didn't have any good solutions, and we just happened upon Todd accidentally. He came to us attached to a client who opened a trust with our organization, and we're like, you do what? And then gold, he gets the text at 9
Dorian
o'clock
is
at
the gold letter.
And so, we found a solution because the mental health system is, you've just seen all these slides with all these words. It is so complicated. I don't know about in other states. In North Carolina, our public mental health system is abysmal. And so we really need to look to the private sector in a lot of cases. And as trustee, oftentimes there are financial resources to pay privately for these services, but just figuring out where to look and what service do I pay for, and doing that cost benefit analysis of, okay, if we have $500,000, does it make sense to pay $100,000 to set this person up for some semblance of success? Or do we just keep buying the lawnmowers and buying the tires and band-aiding the crises until the money's all gone? And so we work with Todd to kind of do that analysis with these really difficult cases. And this first client, Todd's long-lost twin, what is truly holds the record as one of our most challenging. We had to shut down the office because of this client for a couple of days. He was calling in bomb threats, not just to us. He called into a few schools as well, so we weren't alone in the bomb threats. But we had his money. And nothing pisses somebody off with mental illness more than the person who's holding their money, right? So we were on the list of folks that he was threatening. And you know, he was very unwell, delusional, hallucinations, just fully psychotic. So not his fault, but he believed that we, among other people, were out to get him. He had cycled in and out of jail. He had cycled, but the jail doesn't want him either, right? So jail doesn't keep him, even though he's threatening to bomb people and kill people. They found zip ties and bomb-making materials in his apartment. But the jail, they don't know what to do with this guy. He ends up in public mental health facilities. They don't know what to do with him either. They send him back to the jail, who says, hey, wait, not it. So it becomes a hot potato. He's a veteran, so he spent some time in one of the VA hospitals, and they didn't want to deal with him, so they bought him a bus ticket. They said, where do you want to go? And he said, I want to go to Greensboro. Guess where our office is? Downtown Greensboro. And so we got the heads up that, you know, he was being dropped off right up the street from our office. So had to send my staff home. So Todd and I had a conversation of, you know, all right, we have X amount of dollars. What can we do to try to get him out of this system of jail, VA, hospital, public mental health? It's not working. They're all sticking Band-Aids on this bullet wound and then tossing them to the next provider saying, this is your problem. So that's where Todd got involved, and I'll let you take it from here.
Well, part of the reason why one of the things that as a therapeutic consultant we get named for is we are continuity managers. You know, because even with these private pay levels of care, they don't always have a full continuum. And so they're going from one program to the next program, and once the gate shuts from one program, they're like, hey, great, best of luck. And they don't keep track of the person after that. We keep track of them throughout the process. Well, even that problem exists even at the highest levels of payment that you can make in the mental health system. Imagine what the community mental health systems look like. Nobody thinks outside of their box. They're in complete silos. They don't make phone calls. They don't reach out. They don't do things. So this guy, he started off in one jail system in the county next to Guilford, which is where Greensboro is. And so I had to call the jail and say, we had voluntarily committed him in one county, called the jail in the other county, and like, can you take him to the police in the other county? Had them pick him up so that those police could take him to the hospital for involuntary commitment. And then, of course, he's a DA, he's under guardianship, DSS case, and who does really nothing, but they did make him stay in the hospital until we had residential treatment, so we'll give him credit where credit is due. So we find residential treatment, and he gets well. He gets on medications. He comes back. My partner in crime back here, Jennifer Stanger, was his coach for a very long time and helped him get new teeth and stay on his medications, and find an apartment, and learn the bus system, and do all the things there locally where he was living. And he even got his rights restored.
Can I ask, he also became a peer support specialist to help others?
Now, this is a cautionary tale, because all of a sudden, doing very well, and what happens when a person does very well? Everybody goes, oh,
They
yeah.
stopped taking their meds.
He stopped taking his meds. He went so psychotic. He's still in jail again, and we're working with him again. So the family knew about us, and we're helping him through this crisis again. As soon as he gets on meds, he's a lovely person. He really is a lovely person. So, you know, it's when a person suffers from these conditions, especially in their 50s, they still have to have some level of support involved. Somebody keeping an eye out. This is why we love care managers. Care managers are great. They know to pay attention to meds. They see symptoms when they crop up. They know when somebody's like, hey, let's take a look. Where's your med box? Did you go to the doc? Did you go to the doc this month? When you have a person who's like that, what we like to find is programmatic implements that are going to last them the rest of their lives. And we can find those because we have a broad network of finding them. We like to find and hand off to resources like care managers, trust managers, and those kinds of things for the longer haul, because that's what you're built to do. Our next one, this is the one that introduced Dorian and I. Dorian, you want to, was it you? Did I get introduced to you or you to me? Who came first, the chicken or the egg?
You know, I don't know. Todd or Dorian, which came first? I don't know. But this was a trust that was brought to us. And it's kind of interesting. Oftentimes when we work with these clients with mental illness, they're very resistant to going into care. So we really have to push and fight for this. This client was the complete opposite. We have this beautiful residential, it's not a long-term residential Cooper so I'm not.
It is now, they've built that out, yeah.
So, a mental health community, and they do a fantastic job, but they can cost upwards of $30,000 a month. They're outrageously expensive. And this client got so comfortable that she wouldn't leave. And so we had, X amount of dollars. We're looking at the bottom line, right? Our job is to look at this trust and make sure it lasts. And the family had already found Todd and engaged Todd prior to the trust coming to us. The family members were serving as trustee, and they have no idea what to do. We took the trust, we were introduced to Todd, and so the idea was, let's find some long-term sustainable options for this individual that's going to set her up for success. And success looks different for everyone, right? But just like the first case, we're not talking about, a $20 million trust where we just have endless amounts of money that we can spend on this very expensive treatment. In some cases, it's just a couple $100,000. So we have to do that cost benefit analysis to figure out how much of this finite amount of money should we spend on these very expensive services. And in the first case, we had to look, the alternative is he's going to be in jail because he's killed somebody or harmed somebody, or somebody's going to kill or harm him. That was really the only next outcome. So it made sense to look at this finite amount of money and say, hey, we're going to spend a big chunk of this to try to give him a chance. Because otherwise the outcome is not going to be good. And yeah, we save the money, but to what end? And so it's always for us in our fiduciary role, that balancing act of, how much do we spend? And then figuring out how to convince the client once they get comfortable in these cushy mental health communities, it's time to leave. There are other resources, and that's where Todd came in to help arrange a more long-term solution for her.
And when I say borderline personality disorder, this woman was a pro. She was a pro. And she would do things like set up a business because she was going to teach Pilates, which she did, and spend $300,000 in 1 year on setting up a business and buying a studio or renting a studio and everything else, none of which panned out or made any income. So she would do that sort of thing, lots of strange family dynamics, lots of contentious kind of relationship with mom, had a child of her own, ex-husband's out there somewhere, etc. So, the long and the short of this is that I was the yes or the no to therapeutic care. What level of care was going to be appropriate? Because it's true, she would go into, and unfortunately, $30,000 is standard private pay rates these days. That's not even high end anymore. 45 is getting closer to the middle. You can pay as much as $90,000 to $100,000 per month for residential care. So at any rate, she would very gladly go spend that money in one of these environments and get no better. That's the important part. So I just got to be the person who said no a lot and had enough of a relationship with her. It's like, look, and she would call at 11 o'clock, I'm suicidal, and she had a doc. Oh my gosh, the doc.
Oh,
yeah.
She had an enmeshed psychiatrist who forgot to bill her $15,000. Yeah, forgot. And then he sent the bill to Dorian. Dorian's like, do we pay this? I'm like, no. So, at any rate, she was 61 at the time. We're just trying to save her enough money. We want her little trust to last until she's 65 and her benefits pick up. And we made it. She now lives independently on her own with benefits. She's very happy. She's on the other coastline now, but she's kind of one of those success stories, and also got basically her rights restored as well. Now, Uncle Billy.
We're getting there. We're still in the thick of some of these case studies, and this is one that we're coming on the other side of the thick of it, I think.
The client number 3 is actually another success story, and we've gotten to bow to he's in a stable place, his meds are managed, he's in a place that cares for him. We chased after him, ex-wife, would go see the ex-wife, they would get into a fight, he would go to jail, and then he would end up in the hospital in a psychotic break. Like, he did that. I chased after him for a year doing that. He went to residential treatment twice. He's finally stable, getting the medical care that he needs, in a care environment that knows how to manage the meds, and he's doing all right now, back in the state. But the one that we're dealing with now is another gentleman in his 40s, and I could hand him $100,000, and when I tell you he wouldn't have it by the end of the week because he gave it away or bought something or did something else with it, and that's all he's got. That's all he's got. So he's been into houses, and we bought him phones, and we bought him furniture, and we bought him refrigerators, and he traded them for drugs, or he sold them, or he gave them away. He doesn't have a thing left. I can hand him something, a credit card that's got $10 on it, and if he's got it by the end of the day, I'd be surprised. He is a child. And now, because he gets placed in housing, he starts using, goes off his meds, destroys the place, or says something mean to somebody, or gets in an infraction and gets kicked out. He's been kicked out of 3 places. He's homeless now. And we're just trying to figure out how to house the guy. And I literally have to engage help to figure out how can we create a situation that's sustainable for this man. He is difficult, and you've seen this before. And of course, because he's got a trust, and they can pay for us to be involved, and I use my fee to pay for others to be involved. It's like moving a large piece of furniture. It's hard to do by yourself, if not impossible. So without us involved, DSS doesn't do anything. I'm screaming at him like, hey, he's homeless. He's at the homeless shelter. Why don't you go see him so you can do an intake with him? It's like, well, we're busy this week, and I missed him the other day, and all the excuses. Chasing after this one, we showed you ones that we hope to be again, but more or less success stories. We do have the ones that we haven't figured out yet. What I've got to do is try to get him clean and sober long enough so that he can stay stable in the situation, and that's the move we're trying to make.
But the nice thing about having a therapeutic consultant involved in a case like this, sometimes clients come to us and the family or the professionals involved don't necessarily disclose to us exactly who we're getting. And so sometimes we stumble into this blindly. The family was very transparent when they came to us and asked us to take this trust. They're scared of him. They said, don't tell him where we live. Don't tell him our phone number. He's dangerous. He might kill us. So they were very transparent, and we thought, oh great, sure, give us his money and give him our phone number. So this is a client that we don't have communication with, and we made that agreement on the front end with the family that we were not going to engage directly with him. We were going to have a buffer in between us and him. Sort of our good cop, bad cop routine that I think we've gotten that one down pat. But Todd is that buffer. So we're on the back end managing the money, and we've had missteps. He needed a TV. Of course you need a TV. That's reasonable. The TV was gone in 24 hours. I need another TV. Well, no. So it's not a well-oiled machine because we're dealing with people, and we're dealing with people who are very sick in a lot of cases. But
he got in my car last week, he turns to me, he goes, I think I'm incontinent. Can we get to a bathroom? So I carry a little carpet thing because in the back of my car, because I have dogs and things like that, I said, hold on a second, and I covered his seat. We got him to a bathroom in time, but yeah, it was a dicey moment for there for a second.
Yeah, so this is what we do, right?
Yeah, right, that's what you deal with. I mean, so.
But for us, it's given us the ability to help families that otherwise we would have had to say no to. And again, this was not a big trust, so the large financial institutions, it doesn't meet their minimum threshold. So they really are looking at, the pooled trust, the smaller organizations to help. And if we had said no, then what? They were holding the purse strings at the time. This is another one where the family had the money. Mom or dad passed away and said, let your brother handle this. And brother's like, I'm terrified of my brother. I can't help him. And so fortunately, we did not have to say no in this case. And so we're trying to figure out, okay, we have this finite amount of money. He's completely unstable right now. So how do we navigate, DSS? Is guardianship appropriate to kind of force him into care? Because he is not one who's saying, please give me the help that I need. And then the involuntary commitment process, dealing with all the criminal piece that's happening over here. And then is the resource in North Carolina? We're a North Carolina-based trust. Or is it in Florida? Is it in Arizona? Todd has found a place in Arizona that might be willing to take him. Because all of these places across the country have their own criteria, right? Maybe they'll take somebody with a mental health diagnosis, but we throw substance abuse into the mix, and nope, that's not appropriate, that's not our population. Or nope, they've got a criminal history, they're actively violent, nope, we won't take them. And so it's juggling all those million different pieces to figure out, okay, how do we as fiduciaries use this money in the best possible way to set this person up for some semblance of success. And that's gonna look different for everybody. It doesn't necessarily mean everybody getting their rights restored and getting a job and, living the American dream, if you will. But success is not dying, is not killing somebody, is not ending up in jail for a lot of these.
I have a little higher bar than that, but
I'm a little jaded. I've been at this too long.
And it goes the other way as well. I keep trying to talk to Dorian about going national because a lot of ours are around the country, but we run into families who are running through all this, and it's like, hey, have you considered a special needs trust and a trust manager and somebody who can handle conservatorship? Like, that is a service that we refer out to all the time, because they really need, as you all know, they need to make a plan. This is going to go on. This is going to be a condition that requires long-term management. You're not going to be here forever. The child or the brother or whoever it is going to continue to need support and care. What are you doing to set up a plan for that person so that when you're not here anymore, or maybe unwilling to deal with it anymore, what are you leaving them with? Because otherwise they're going to be on the streets or homeless or in jail. That's where they go. Or dead, in truth. But, I'll save a little time so you guys can ask some questions if you need to, just to, what can a therapy consultant do for your team? Stop a revolving door crisis. Navigate behavioral healthcare systems. Serve to mitigate difficult family dynamics. Say no to difficult beneficiaries. I want a TV. No, I just bought you a TV. Write support letters, work with courts, file with courts. We do evaluate clinical data, digest it, in a nice chunk. People love it when I take the 20-page neuropsych eval and give it back to them in one page. They really like that. And then, in summary, basically, we like to work together, but if you're gonna go somewhere, go with somebody who's got a map. And we travel the country so that our map is accurate, because you can't just rest on your laurels. You can't just sit there and be like, okay, well, I knew this program 3 years ago, but they got bought by some major corporate conglomerate, and now they take nothing but insurance, they're a network, but the quality of care is really poor. Like, things change, things happen to programs, and laws change. and all of a sudden you've got a care environment that's no longer suitable for a person, they end up having to leave the state. California is a great example for adolescents and young adults right now. And so, you know, you've got to be paying attention to the field. And if you're not, you may put your person into a situation where they're gonna, you know, experience more harm than good. So that's what we try to navigate for and with during places like Guidance Carolina, and work with care managers and trust officers and the like.